Good afternoon, everyone. Welcome to ALS United Greater New York's Summit of 2024. I'm very honored to have the pleasure to be moderating for Esther Kane's presentation on FTD and understanding ALS. Esther Kane joined AFTD, the Association for Frontotemporal Degeneration, as its Director of Support and Education in November 2020. Previously, Esther served as Director of Wellness at Care One Management, a company that provides elder care services throughout the Northeast US. She brings clinical, educational, managerial expertise, along with a passion for quality care for those who are living with neurological conditions. In her work at AFTD, she strives to ensure appropriate care and support is available to every person affected by FTD and educates healthcare professionals to improve diagnosis and care. Her work reflects a strong commitment to the importance of education and training throughout the spectrum of diagnosis and delivery of care. You all can put your questions in the Q&A on Zoom or in Whova, and we will get to them at the end. So welcome, Esther. Thank you for being here.
Yeah, thank you, Donna, and to the ALS United Greater New York for inviting me today and letting me come and talk to you more about understanding the FTD in an FTD ALS diagnosis. So I really hope today that you'll just have a better understanding of what FTD is, the relationship between FTD and ALS, and also a broadening understanding of what it's like to live with that dual diagnosis and some considerations and things that we may want to take in as we are looking to provide care and support to others. So my goals today are to broaden your understanding of FTD-ALS, to describe common symptoms. I also want to look a little bit about some of the approaches to FTD behaviors, and then to review support for persons diagnosed and their families. So what is FTD? Frontotemporal degeneration, which is the term we use for FTD, is a type of dementia, one of the many types of dementia, that's caused by a family of related diseases or disorders. Symptoms typically begin between the ages of 45 and 64, although age of onset can range anywhere from 21 to 85. I just talked to a man who is 85 diagnosed with FTD. It is a leading cause of dementia for those under the age of 60, though, and a majority of cases do occur in those between the ages of 45 and 60. A genetic cause can be found in approximately 20% of those diagnosed with FTD. And this number is growing. That's really with only the genes that we know of that this is found. And we're learning more and more every day about the genetic implications and considerations that we need to think about when somebody has an FTD diagnosis. And this is really important when we talk about FTD ALS. I'm going to talk more about that in a little bit. But what we're finding is a strong genetic link between FTD ALS and those living with the disease. FTD initially presents with different symptoms depending on where the disease starts in the brain. The most common early symptoms impact behavior, personality, and communication. Unfortunately, right now, it can take on average 3.5 years to get a diagnosis. And because of the typical younger onset of FTD, many persons with FTD or their care partners can still be working with their medical insurance related to employment, still paying off a mortgage or other loans, be saving for retirement, paying for college, etc. When we look at frontotemporal degeneration, it's a cluster of complex disorders. So it's not just one disease that we're looking at. The three main functions that we're looking at are changes in behavior, personality, which we describe as behavioral variant FTD. We also have changes in language, which are the primary progressive aphasias, which I'm going to talk more about in a few minutes. And then we have changes in motor function. And here we have the atypical Parkinsonisms, which we call corticobasal syndrome and progressive supranuclear palsy, and then FTD with ALS or FTD and motor neuron disease. So what's happening in the brain in FTD? What we start to see is damage is occurring in the frontal and temporal lobes of our brain. And this is so important because the frontal lobe of our brain is kind of like the CEO of our brain. It controls our executive functioning, our behavior, our decision-making, our problem solving, our emotional control, our impulse control, our safety awareness, and some of our physical movement. And when we start to see changes in this area of our brain, we start to see some of the symptoms that are really evident in FTD. In addition, the temporal lobes of our brain really control our language and speech and how we process language and speech. And so we see very often when people start to have a primary progressive aphasia or changes in language, we're going to see damage in the temporal lobe of the brain on MRI or CAT scan. In addition, the causes of FTD are split into 3 categories. The majority of FTD appears to be sporadic. These are families with only one person diagnosed. No one else in the family has FTD or a related condition. The presumption is that relatives are not at risk. In these cases, scientists are still working to understand what is causing the disease. We don't know why it's happening. Familial FTD accounts for roughly 40% of people diagnosed. And in these families, there are multiple people with FTD or a related condition like ALS, which is generally related to FTD, or other diagnoses. Sometimes they have a family history of Parkinsonism or behavioral or psychiatric conditions. When we see FTD and related conditions cluster in a family, we refer to this as familial FTD. And in this section, there's about 20% of the time, 15 to 20 and growing more, that we see a known genetic risk for what is causing FTD. And most of the time, about 75 to 80% of the time, when somebody has an FTD and an ALS diagnosis, there is a known genetic reason as to why this is occurring. And so FTD and ALS are strongly connected and linked to genetic causes of the disease. And we'll learn more about that as the slide goes on. And I hear there's another breakout later today or another session on the genetics of ALS. So I don't think this is a subject that we don't talk about a lot, and we're talking about it more and more so that the communities and people are aware and they understand what's happening and they can make family and life decisions appropriately for themselves and for the rest of their family. So when we look at the genes that are seen in FTD ALS, the most common gene we see is called C9orf72. It's a repeat frame mutation or change that we're seeing. In addition, there are some other genes that we see people can have FTD ALS with. And then there's more that we just don't know about and we're still learning about. So this is a sampling of some of the genes we see, but there can be others. And science is continuously learning more and more about what is happening in individuals who are diagnosed with FTD and ALS. So diagnosing FTD, this is a complicated process. As I said earlier, the average time to diagnosis for FTD is about 3.5 years. And so when you have a disease that has that long to get an accurate diagnosis, that leads to so much added frustration and inability to plan for the future for families and those diagnosed. Right now, when we diagnose FTD, the only definitive way of getting a diagnosis is through autopsy. But typically what we do is we get a probable diagnosis. And if you have an FTD ALS diagnosis, that is most likely the diagnosis you were given. And what they're looking at is MRI or PET scan imaging, trying to see, is there damage or atrophy occurring in the frontal and temporal lobes of the brain? And then in addition, they're looking at neuropsychological testing and they're evaluating symptoms. What's happening with the person? What are the changes that we're seeing? The 6 most common behavioral symptoms we see, and I'm going to talk more about this in a little bit, are apathy, disinhibition, loss of empathy, executive dysfunction, compulsive behavior, and hyperorality. And then in language, we tend to see changes in word finding, changes in word understanding, and changes in word order. So when you're talking about somebody with FTD ALS, they can present with language changes, or they can present with behavioral changes that are evidenced within this diagnosis. So over the last 10 years, there has been increasing recognition of a continuum between ALS and FTD. Up to half of people with ALS also show symptoms of FTD, while up to 30% of people diagnosed with FTD develop motor symptoms consistent with ALS. People diagnosed with either ALS or FTD may feel overwhelmed by their situation and miss or overlook possible signs of the other syndrome. But a potential dual diagnosis is important to consider due to its impact on treatment, prognosis, and understanding the genetic risks involved. Diagnosing cognitive and behavioral impairment in ALS requires a comprehensive neuropsychological evaluation, as I discussed a little bit earlier. The evaluation should include standardized measures that allow for appropriate control of writing and speech impairments the patient may have with ALS already. The Strong's criteria for diagnosis is the gold standard to identify ALS FTD. And here we're looking for progressive deterioration of behavior and or cognition and presence of at least 3 of the behavioral cognitive changes associated with BV-FTD, or at least 2 of those cognitive behavioral changes associated with BV-FTD together with loss of insight or psychiatric symptoms, or the fulfilled criteria for primary progressive aphasia. So it's a little bit complicated and a lot of information to say that a detailed neuropsychological evaluation is important in understanding whether or not we are seeing symptoms of FTD in the ALS individual. So what do these symptoms really look like? What does it mean to have FTD and understanding the behavioral symptoms that are happening? So like I said earlier, our frontal lobe, our executive functioning part of our brain, it's the CEO of our brain. It really controls a lot of our decision making and our thinking and our processing. And it really helps to identify who the person is and how they react and behave. And I think this is probably one of the hardest parts about FTD, specifically in behavioral variant FTD, because at times the person's behaviors can change and they change what the relationship looks like between the spouse and the caregiver. And so we want to look at this a little bit and better understand what's happening in these particular symptoms and how can we better support those living with the disease as well as the care partners and the families who are involved. So apathy is one of the more common first symptoms. It typically is seen as an indifference or lack of interest in previously meaningful activities. So all of a sudden, they just don't have the desire to go for a walk. And maybe they were an avid walker and they went all the time. They're struggling to get up. A lot of times what we'll see in BV-FTD is this evidence actually in their work life as one of the first times we start to notice symptoms is, something's not right at work. This really active, engaged employee is no longer active and engaged in the same way. And companies it affects their work performance. And that tends to be a big indicator that something is going on. You may see with somebody living at home with ALS that they just don't have any energy to do anything, and apathy might be really prevalent. Sometimes sitting in front of the TV for long periods of time, and just general lack of interest to get out of bed, change clothes. I think something really important to understand, though, is it looks like depression, but there's no sadness associated with it. So apathy in FTD is not necessarily, it's not depression, even though it looks like it. There's no crying, there's no sadness, they're not upset. They just have no motivation to do anything. Behavioral disinhibition is another very common symptom we see, and this is a really troubling symptom for persons diagnosed and for their care partners. There's a loss or lack of restraint based on social norms. So we'll see people walk up to somebody in a restaurant or they'll be out eating and they'll say something totally inappropriate. Maybe there's a new nurse that comes to the house and the person might say, you know, you're really sexy today. Something that they might not have normally said that probably is not appropriate to say to your nurse. And they're losing their ability to kind of filter or think through and process what it is they're saying. They're just saying it. It came to their mind. They just said it. I give an example a lot. I was at an event and somebody just walked right up to me. It was an FTD event and there was people with FTD there. And somebody walked up to me and just kissed me. He was like, I just wanted to kiss you. I saw you from across the room. And I was like, okay, that makes sense. But for him, he just didn't think that maybe that would be appropriate. He saw me and he just wanted to plant one on me and he did. The person may make, like I said, uncharacteristic, rude, or offensive comments. They also might be reckless. So sometimes we see shoplifting or reckless spending. They're on their phone all the time, buying things out of control that they normally would not have wanted. Inappropriate sexual behavior, as well as aggressive outbursts. They just don't have the ability to kind of control what they're feeling. And so the feeling comes out right away. There's no censor there. There's no little person on their shoulder saying, maybe that's not appropriate. That person is no longer there anymore. We also see something called loss of sympathy or empathy. It's very common, and I think this is really hard in family members. The person who once cared deeply about you is no longer showing that they care anymore. They no longer have the desire to attend events or be present. And it's very difficult on roles and relationships. In addition, we see a lot of compulsive ritualistic behavior. Some people might be picking. We hear a lot from families where they're picking skin on their fingers, or they're continuously walking the same path over and over again all day long, or they have the same routine that they keep up all day long. And we'll see that quite often in FTD, specifically in behavioral variant, but also in semantic variant PPA. And then we see changes in eating habits. There's a lot of excessive, compulsive, or inappropriate eating or drinking. And then FTD ultimately causes deficits in executive functioning. So there's just poor judgment, poor problem solving. People with FTD are really prone to scams. I hear very often from families where people gave away hundreds of thousands of dollars. They send money overseas. They just don't have the same capacity anymore to make those decisions. So a diagnosis, as I said earlier, of probable BV-FTD requires at least 3 of these symptoms. They can be any one of the 3 of these symptoms, which is why we see so much change in people who are diagnosed with FTD. We say all the time, if you've met one person with FTD, you've met one person with FTD. And very often what is displayed in one person may not be what is displayed in another. And so we have to be mindful of that and thoughtful of that when we're working with families or when we're talking to care partners or those who are living with the diseases. It can present in a lot of different ways. I had a family tell me that when I talk about this, I need to just really show how significant some of these behaviors can be, because it's not just executive dysfunction. And these were some examples that some families had given me about what it looks like to have FTD. So one of them, somebody was going through, they went through a $400,000 inheritance in 3 months. They spent it all. They gave it all away. It was all gone. Another person was running red lights and not stopping at stop signs. That disinhibition was there. She just wasn't even thinking about it. She was going right through. Even though she could drive appropriately, it wasn't safe anymore. She was also caught shoplifting candy. The family had to take away her car keys. Another instance is that somebody was walking out to liquor stores, taking alcohol out and just walking right out with it. Didn't even think twice about it. Talking to strangers and asking inappropriate questions, which I mentioned a little bit, or excessive behaviors. Sometimes we also see hypersexuality behaviors too, because the thing you're thinking is just happening. You don't have, once again, that kind of block that says this is appropriate or not appropriate behavior anymore, which is what we're talking about when we say changes to social norms. Something we see quite often that is a really common symptom and that really exasperates what it's like for people to live with FTD is something we call anosognosia. And anosognosia is when the person diagnosed starts denying anything is even wrong. They don't think they have anything happening to them. They don't notice the changes. They deny the symptoms and what they're seeing. This is also referred to as a lack of insight, and it's one of the hallmark symptoms of FTD. It's pretty common, especially in behavioral variant FTD. People who present with anosognosia display a profound lack of emotional concern about their disease and its impact on their family members. Even those who acknowledge they have a brain disorder may deny they are upset or worried about their condition. Anosognosia is one of the main reasons people with FTD refuse medication and medical personal care, which you can only imagine how complicated that can be in an FTD ALS diagnosis. People with anosognosia may be able to function normally in some areas of their lives, yet demonstrate risky behavior elsewhere. And this is where it gets really difficult because they might still have some function in part of it and be operating okay, but in other areas not be doing well. And this anosognosia can just be a very complicating symptom that families deal with. So what do we do? How do we manage? How do we manage these symptoms to improve the quality of life of the person diagnosed? Because that's always the goal, is that the person living with the disease can have the highest function and highest quality of life that we can possibly try to provide. And that can be really hard when they're losing function, when they're losing ability to speak, when they're losing ability to make decisions appropriately. And then at the same time, they're dealing with muscle weakness and loss, and they are having less energy, and they are having nutrition issues. These things all kind of combine in FTD ALS to lead to what can be a really added aggravating situation for these families. And so when we're looking at apathy and managing apathy, some things that we like to talk about are trying to figure out where the apathy is occurring. Why does the person apathetic? Is it an issue in initiating action? Is it an issue with impaired planning? Is it an issue of lack of motivation? And what steps and tools can be put into place to help the person kind of move past it? So for example, some people just may not be able to process out a plan to be able to do something they could once do. We see this often in, let's just say, brushing your teeth. We'll use a simple example. The concept of taking the toothpaste, putting it on the toothbrush, taking the toothbrush, putting it up to your mouth, brushing your teeth, spitting, rinsing, brushing your teeth, spitting, rinsing, brushing your teeth, rinsing your toothbrush, and then maybe mouthwash or whatever your procedure is. That was at least 10 steps that the person had to go through in order to complete that. To you or I, that might seem like it's a normal daily behavior. We don't even think about the steps that are required in order to complete that. But when somebody has severe apathy, sometimes they don't have the ability to process through the steps of an action. So the more that you can help them through the process, like saying, all right, here's your toothbrush. Now put the toothpaste on your toothbrush. Now take your toothbrush, rinse it in the water, put it up to your mouth, going step by step with the person. Sometimes in some people that will help them be able to go through the process. But it's difficult for care partners because you don't always recognize when this is occurring or why this is occurring and what support the person needs, especially if they're functioning well in another area. This inhibition, which we talked a little bit about before, is really troubling for families. And I think I actually covered most of this. So I'm going to skip through this because I have a slide later talking about managing expectations. And I think when we're dealing with disinhibition, it's really about the environment and how we can change the environment to support the person. So deficits in executive functioning skills, what we really want to think about is safety. Is the person safe? Are they safe to still live alone? Should they be driving? Is driving still an appropriate thing for them? Are they prone to financial scams? Do we have to put things in place to protect finances or to protect the person? Are they breaking the law? Are they shoplifting? Home safety. Are there guns in their home? You have to think that people are very impulsive. Those diagnosed with FTD are very impulsive. They don't always think through a process. So when it comes to safety things, are they going to think through to turn the oven off? Are they going to think through to turn the water off? Are they going to think through the safety of having a gun in the home? And so these are all things that you have to process and think about. But one of the most important things that we always want to talk and be cognizant of is that we want to look at the person. I hate to sometimes go through these symptoms because I don't want people to attribute every symptom to the person diagnosed, right? What we really want to do is see what's happening in the person, and then based on what we're seeing, come up with mechanisms and care plans to be able to address the person's specific needs. So this may not be true for everybody. Some people might be able to live alone for a little while on their own, and other people may not be able to live alone at all. And so we really need to assess and look at the person as a whole and assess what their needs are. And then also see how else we can put things into place to support the person who is living at home or in any environment for them. When we look at lack of empathy, I think some of the things that families deal with is the concept of, why don't they care? Why don't they care anymore? Am I not important anymore? This is especially true when there's a parent, I think, involved, and with a spouse, is your relationship is changing. You know, typically the way that we view relationship and how we view how we work with others and live with others, it's a give and take. And when you feel like you're constantly being taken from and there's nothing coming back, it can be very difficult for relationships to be managed. We hear from a lot of people who end up getting a divorce, specifically in the early stages of FTD, not realizing that there's a neurodegenerative disease taking place, and instead thinking it's just a relationship issue. And so it's important to really think about it and to consider, what can we do to separate the situation from the person. I've had a lot of people they name the disease. So they'll name the disease Bob or Joe or John or Doug or whatever they want, Kathy, whatever the disease is. And it's always a different name than somebody that's in the family. But when something happens that's within the disease, they say, oh, that's just the disease. It's just Doug. It's not, my spouse. And when they do this, they're able to separate the disease behaviors from the person, which allows them to recognize what's the disease and what's a purposeful action of the person. And in some cases, it can help with the relationship and the caring of the individual. We talked a little bit about compulsive behaviors, which are really common too. People with FTD, these behaviors include repetitive movements. It's nonstop, to the point where sometimes it's really frustrating. But I think with these types of behaviors, what we need to consider is anyone being hurt? So although it might be annoying the care partner or the caregiver or the family, it may not be annoying the person. So is anyone being bothered by the behavior? Are they safe? So when people are going for long walks, maybe in an unsafe area, maybe they're walking in the rain or the snow where it's not safe, maybe they keep walking over busy highways, then maybe we need to do something because this is a safety concern. But if they're constantly tapping, maybe not. And this is different for every family, right? If it's causing the care partner extreme stress or duress, then yeah, in those cases, we need to consider that. And we need to make sure that the quality of life of the care partner is considered too in this process. We all know the saying, you can't pour from an empty cup. And when care partners are constantly giving and not being cared for too in their mental health, that can lead to exacerbated symptoms and just an inability to manage them. So then we're going to talk a little bit about primary progressive aphasia. I know I went through those behaviors pretty quickly, and you can feel free to reach out to our helpline, which I'll talk more about in a little bit. But if you heard nothing else in the last statement, I hope you just heard that every person is different and not all people are the same. And so what that looks like in every person is going to be different. But we want to make sure we're tending to the person as well as the care partner in all of these situations. So primary progressive aphasia, there's three main kinds. Typically what we'll see in FTD ALS with the language loss is more of the non-fluent agrammatic or semantic variants. Logopenic primary progressive aphasia is actually caused by Alzheimer's pathology, which is a little bit complicated, but all this to say is that all of these diseases cause changes of language and an inability to communicate. And so when we're supporting those with these changes in language where they start to lose words, they can't find their words, it's important that we come up and we look at mechanisms to support them. In all cases of primary progressive aphasia, what we really want to do is get a speech therapy consult involved. Speech therapists can do a lot, especially speech therapists who are trained in aphasia, to develop adaptive mechanisms to help the person to be able to communicate at their best level for as long as possible. You always also want to not assume a lack of understanding when there's language loss. So as language is occurring and changing, this does not mean that the person is not understanding what is happening. Very often it's more of a retrieval issue that's occurring, or an inability to have the motor function within the mouth to speak the word. And I think the more we can recognize that it's not a cognitive change, it changes the way we address the person and how we treat the person. We also want to reduce background noise. It's really important that we take into consideration the room you're in. It's difficult to talk to somebody in a really busy, noisy place. So if somebody is experiencing language loss, you want to go to a quiet room and you want to look them face to face so that they can read your lips, so that they can have the best communicative experience with you at one time. Sometimes we'll suggest practicing and rehearsing personally relevant words like names or things that they need to say over and over again to help them be more successful. We also want to give direction or ask a question one at a time. And we want to use short sentences and affirming statements. And we have more of this information on our website. This is a quick breezer, but specifically the communicating with persons living with PPA tips and strategies, you can utilize them with anyone with language loss, and they can be a support specifically in the FTD ALS space, which kind of leads us to our next slide. And I think what we really need to talk about is when FTD and ALS collide. And in more and more individuals, we're seeing this FTD ALS diagnosis. So we have all of the behavioral symptoms that we're seeing in FTD: lack of insight, impaired executive function, apathy, language loss, which would be difficult to manage and live with on its own. But then we're also seeing ALS symptoms. So there'll be dysphagia, difficulty breathing, muscle weakness, muscle spasticity, all of the things that can occur in an ALS diagnosis are now combined with FTD. And very often these people, they get a double whammy. It's all going on at the same time. And when we look at care and how we want to approach the disease, we really need to start from a person-centered approach. Very often, a lot of the care paths and the ways that we look at goals of care in ALS may not be effective if somebody also has FTD. So for example, in some people, you have to really look to see, is the PEG tube helping? Is it helping deliver nutrition, increasing energy? Is the person tolerating the PEG tube? Are they willing to have the PEG tube in? Because sometimes if they have dementia, FTD, and they're having these behaviors, they may be ripping the PEG tube out. It may not be an effective mode for them while they're dealing with it, while others may actually really appreciate the intervention. It may give them more energy and they may feel better by having the PEG tube. The same thing we need to consider with breathing. And, when we're looking at ventilators or BiPAPs or different things along that line, if they're not going to keep the BiPAP on, that's probably a good sign that they're not going to keep the ventilator hooked up either. And we have to look and see as to what is going to be the best method to support the person. Now, this is not true of every person with FTD ALS, but we really have to assess the person, and the family really needs to think about what is going to work. Because sometimes in an effort to try different things, they will try to do a PEG tube and then it has really adverse effects. There was surgery, the person's pulling at the PEG tube, we're looking at other modes of restraints and things along the line to keep the PEG tube in, and that may not have been the goal. And the ultimate part of this is really about having early discussions and understanding, really having those discussions with neuropalliative care, discussions with the family, discussions with the person diagnosed. Early discussions are going to help you be able to meet the person's needs and understand what their wishes are, what it is that they want from the next couple of years or during this time, and how can we best support that, and what does it look like? And so we want to have discussions too about if cognition changes or comes into play where they might not be able to make these decisions for themselves anymore. What do you want and what wishes are most important? So if I tell you anything today, having those discussions early is one of the most important things that you can do in helping you plan for the future and how to care for somebody with this disease. And once again, I want to say that every person is different. I've had people who've been really successful and they've been a huge support to be able to use to get a PEG tube or to have a BiPAP, and it's been great. And then I've known of some people where it just was really difficult to manage. And so those discussions between the family and the doctor are just so important. The other thing we want to think about is when we're managing difficult FTD behaviors in the complex is we want to modify the environment. We can't modify the person. The person diagnosed has no ability to alter or change what they're experiencing or what's happening. They have an illness, and the illness is not just affecting their muscles or, their lungs or other parts of their body. It's affecting their brain. And so they have no control over what's happening. It's affecting every part of them. And so some of the things we can control, though, is the environment. So what can we do? Well, we can minimize noise and stimulation. We can keep it calming. We can try not to overstimulate. Rest is really important. Taking breaks, letting the person decompress so that they can go on are really important considerations. We also want to reduce clutter and distractions. Soothing, clean environments are going to help the person be more productive and have less agitation. And then we want to simplify. If we're going to have social situations, try to do them one-on-one in small environments. I think this is even true within ALS in a lot of ways because, there's so much energy that's going out just trying to function that, being in smaller, more intimate settings is a little bit more productive than trying to put somebody who's already struggling to, breathe and move and do all those things in a really loud environment. So minimizing is always going to help the person to be more successful and have more meaningful interactions. And then we really want to manage expectations. The behavior is not on purpose. Nothing happening is on purpose. I think I've said this 12 times now because I think it's really important to be able to say. We need to manage our expectations and what we think the person should be able to do and can't do. And sometimes that's really difficult because we've already had plans and our plans have to change. In addition, we want to see, is the behavior hurting anyone? And then, like I said before, we want to modify external outings. I want to give a little plug for neuropalliative care. So I think specifically in an FTD ALS diagnosis, neuropalliative care can be so supportive. Neuropalliative care is an emerging subspecialty, and what it really looks at is, balancing the care needs of people with neurodegenerative diseases. It can be started at the time of diagnosis. It can evolve with the person, and it really focuses on relieving physical, emotional, and spiritual distress. So, it's lovely that many of those diagnosed with FTD ALS can get the support of the ALS clinics, but very often if they started with an FTD and then rolled into having ALS, they can have a lot of, they spend a long time without a lot of support. And so, I think neuropalliative care is a great model to help the person be as effective as possible. We also talk a lot about building a care team. And what we really want to talk about is bringing in all the specialists. And I think the ALS clinics do this lovely. They really bring in everybody that the person needs to help them be as successful and have the best quality of life as possible. And in FTD, this is equally true. You need to bring in the specialists to provide the support, to help you get the resources, to help you find the caregiving support, the medical support, the emotional, spiritual support to meet your needs. In addition, we really recommend that people talk to a genetic counselor, specifically with an FTD ALS diagnosis. Genetic counseling does not mean that you need to do genetic testing, but you should have the conversation. Genetic counselors understand the disease, they understand the implications for your family and what's happening. They can provide disease education information. They provide emotional support because they understand the added complexity of adding genetics onto an already compounding disease process. They can provide guidance and wisdom for your family for future planning. And they can provide tools and support in discussing risks or status of family. And so genetic counselors are great tools in the battle against managing a disease as complicated as FTD ALS. So what do you do? Well, I'm going to talk a little bit about some supports AFTD has in addition to the many supports that the ALS United Greater New York has. So one is our helpline. AFTD has a helpline. It's staffed by trained social workers. If you're dealing with difficult behaviors, if you need questions, if you need support, you can reach out to the helpline at any time, and they are happy to answer your questions, to meet with you, give guidance, and anything that we have that might be able to help you on the journey. In addition, AFTD has a CompStat grant program. So if someone is diagnosed with an FTD ALS diagnosis, they have to have the FTD part of it. They are eligible to apply for these grants. We have a respite grant that helps full-time unpaid care partners attend to their own emotional, psychological, and physical well-being. So you can actually use this respite grant to pay for somebody to come into the home to help care for your loved one, or you can use it for mental health support for yourself. Some people use it for yoga or other caregiver support mechanisms. We also have a quality of life program, and this grant helps people living with FTD access services or supports to improve their quality of life. So some people use this to buy things like recumbent bikes or adaptive equipment for the home. If they had a hobby, they might use it to purchase something for the hobby. But this allows people to be able to do something for themselves who are living with the disease. And very often it changes. We've had people use it to go to a baseball game with their grandson, or various different reasons. It can be an open use. And in addition, we offer travel grants to attend our annual education conferences. We also highly recommend that you find support. Nobody can manage an FTD ALS diagnosis on their own. So AFTD does have an FTD ALS national support group. You can call the helpline and they can get you connected to that support group. It's run by a social worker whose husband had FTD ALS. And it specifically looks at, others who are dealing with the same difficult decisions and discussions to be able to find support. In addition, AFTD and ALS United has many support groups to meet your needs. There's also some other patient advocacy in the genetic space that has support groups or mechanisms that you can join if you're a child of somebody and it's a known genetic variant and you want to join. There's many different options. AFTD also currently offers a support group for people who have a known genetic variant in their family. So C9 runs in your family, but you haven't tested and you don't know if you want to test. We have a support group for that. And we have a support group for those who have tested and who have tested positive and who are looking for others who are in the same situation. So in addition to the FTD ALS Care Partner Support Group, we have support groups for those who are recognizing it's genetic in their family and looking for supports for children and grandchildren, etc., nieces, nephews. So there are many FTD clinical studies and trials that are underway seeking participants. Currently, right now, there is not a clinical trial in C9orf72, but there are many ALS and FTD clinical trials that are happening that you can look into. There is a thing called the FTD Disorders Registry that those with FTD ALS can register in and be notified of any trials that are currently occurring for those with FTD ALS. If you want more information about that, you can reach out to our helpline. And up and coming, AFTD is offering a webinar for healthcare professionals on FTD and ALS, a collaborative approach to diagnosis and care. It's going to be presented by Dr. Semu Babu and Dr. Eldoff of Mass General Hospital in Massachusetts. And it has CMEs and CECs available. So if you're interested, you can go to our website to learn more. And now we are open to questions.
Thank you so much, Esther. That was really, really great and really informative. Appreciate that. We do have some questions. For starters, I just want to let everybody know that this has been recorded and it will be live on our website early next week. So I know there was someone who was a little concerned about missing everything because it's such a great presentation. So it will be available next week. Is the Comstock grant available for all states?
Yeah, it's a national program. So you can live in any state. You just have to have an FTD ALS diagnosis. It can't just be an ALS diagnosis.
Okay. Someone wrote, my husband has ALS and the C9 gene. His brother died of frontotemporal dementia and he's having difficulty with words, but also has hallucinations. Is
Mm.
that part of FTD?
It could be a lot of things. So, when somebody has the C9 gene in the family, some people present with ALS, some people present with FTD, and some people present with a mix of both of those symptoms in one person. So the language losses could be signs of FTD, but I really recommending you talking to your doctor about getting a neuropsychological evaluation done. They can do the neuropsychological evaluation if you talk to your clinic. And then you'll know more and you'll better understand what's happening. Sometimes the hallucinations can be caused from other issues that are happening. They're not just caused from the FTD. Hallucinations aren't super common in FTD, but they are common as changes are occurring in the brain, and sometimes we see it in other things. So it's a question to really talk to your doctor about.
Okay. And are there, I mean, I know you mentioned the different support groups. Are there support groups specific for caregivers for a loved one with ALS FTD?
Yeah, so AFTD has a support group that is just for care partners of somebody with FTD ALS. So if you're caring for somebody with an FTD ALS diagnosis, you can call our helpline and we have a support group that meets once a month and it's just FTD ALS caregivers.
Okay, great. Okay, and another question. Hi, Esther. Our neurologist had put my husband on Aricept when made him very zombie-like. After learning things and speaking to the doctors at the conference in Houston, I made the decision to take him off. Oh, sorry, this is just a comment. It has made a huge difference and he's much more like his old self. Just thought you should be aware. Thank you.
That's great. I
Um,
think I know who that was. So I'm glad that you were able to go to the conference.
Are there any approved treatments, medical treatments, medications specific for ALS FTD?
So we're really treating different things, right? So we're treating
Right.
the ALS through what we know to be best practice in care for those with ALS. And then the FTD, there are no approved treatments for FTD. There are some medications that are commonly used to treat behaviors. So once again, we need to look at quality of life. We need to look at the person and saying, okay, what's happening in the person? Are the behaviors affecting the person's quality of life? Are the behaviors making them not compliant with doing some of the things we know will improve their quality of life on the ALS side? And do we want to look at pharmacological interventions? Sometimes there are some medications that can help support if they're really agitated or anxious, that can be really helpful and supportive. But one of the issues with FTD and ALS is we have to be considerate of how will this affect the ALS side of things, as well as how will some of the ALS things affect the FTD side of it, which is what is so complicating and compounding for those who were diagnosed with FTD ALS. I work in the FTD space, but I had a very close family member who had ALS. And so I know what it's like. We helped care for her and we were in the room with her. And so I can't imagine what it's like trying to manage this dual diagnosis and what that looks like on both sides. So you need to talk to your doctor. You need to have some good conversations with them and say, this is what I'm seeing, and really think about what's in the best quality of life of the person, even if it may not always be the best recommendation, if that makes sense.
Yeah, that's great. All right, I think that's it. Thank you so much. Again, it was a pleasure having you, and it was a really great presentation. And for everyone else here, at 3:15, the next presentation will be on genetics and ALS with Ellie Harrington. So hope to see some of you there.
Yeah,
Take care. Thanks
definitely.
again.
Oh, you're welcome. Have a great day.
Take care. Bye-bye.